EUS guided radiofrequency ablation of pancreatic neuroendocrine tumor. The first case is a 51-year-old gentleman who had presented with recurrent admissions due to hypoglycemia and on evaluation was found to have a pancreatic head mass of approximately 2 centimeters. On CT scan, it showed hypodense lesion in the head of the pancreas with contrast enhancement. And on Dotatok scan, there was SSTR overexpression in the pancreatic head, suggestive of a neuroendocrine tumor. On linear echoendoscope, this hypoechoic lesion was noted, which showed strong E-flow on color Doppler and hyperenhancement on contrast-enhanced EUS, suggestive of a neuroendocrine tumor. The biopsy revealed a pancreatic neuroendocrine tumor, grade 1. This was an insulinoma, and the patient even developed an episode of hypoglycemia immediately after the biopsy. The patient had declined surgery and hence was planned for an EUS-guided radiofrequency ablation. The principle of EUS-guided radiofrequency ablation is to localize the tumor using a linear echoendoscope, and once the tumor is localized, the US RFA needle is punctured deep inside the tumor, and after connecting with the RFA generator, the tumor ablation is carried out in a linear fashion, starting from the distalmost part and pulling the needle in a proximal fashion, causing a slow ablation of the tumor. This is the US RFA system consisting of the needle handle, the RFA generator, and the needle tip. The whole of the needle is insulated except for a small portion of the distal tip around 5 to 26 millimeter, which is naked for the ablation effect. So this tumor was localized on EUS, and after localization, the RFA needle was punctured inside the tumor and the RFA generator was switched on, causing a ablation. The ablation was carried out in a linear fashion with the bubble effect being noted, bubble effect or the cloud effect being noted. Once the one fragment of the segment of the lesion has been ablated, a repeat ablation is carried out in a linear fashion in a different location. The E-flow is usually switched on in order to localize the proximal end of the ablation effect. A contrast-enhanced EUS was done 48 hours later, which showed that there was hypoenhancement in the center with enhancement at the margin, suggestive of some amount of viable tissue at the periphery, and hence a contrast-enhanced US-guided radiofrequency ablation of the peripheral marginal viable tissue was carried out in order to achieve complete ablation of the tumor. In this fashion, the patient had undergone 4 sessions of radiofrequency ablation, after which there was complete ablation of the tumor and the hypoglycemia of the patient had resolved. Similarly, the second case was a 52-year-old gentleman with hypertension and diabetes, and on health surveillance had revealed a mass lesion in the neck of the pancreas. On CT, this isodense lesion was noted in the neck of the pancreas, and on EUS showed this hypoechoic lesion of around 1.5 centimeter, which on biopsy had revealed a pancreatic neuroendocrine tumor grade 1. This was a non-functional NET and hence was planned for an US-guided RFA. In a similar fashion, the hypoechoic lesion was punctured with an RFA needle. The needle is usually advanced towards the distalmost part of the tumor and gradually pulled in a linear fashion proximally while the ablation is being carried out. In this fashion, a line ablation is carried out. Usually, the target of the line ablation is first towards the right lower quadrant of the tumor. As you can see here, the ablation trajectory has burned the right lower quadrant, and then the other parts of the tumor are targeted in a similar fashion, carrying out line ablations. In this particular patient, 4 such linear ablations was carried out in order to completely ablate the tumor. A repeat contrast-enhanced EUS was done 48 hours later, and on contrast-enhanced EUS, it showed that there was complete hypoenhancement of the center as well as the periphery of the tumor, suggestive of a complete ablation of the tumor. There was no post-procedure adverse events, and a repeat imaging of this particular patient is planned at 6 months. Thus, US RFA is a promising newer modality for tumor ablation. US ablation in pancreatic neuroendocrine tumor using radiofrequency ablation, both for functional as well as non-functional tumors, is safe and effective for patients who are non-surgical candidates or those who are not willing for surgery. The procedure can be repeated if needed with real-time contrast confirmation of the completeness of tissue ablation. Choosing the right patient and using the optimum technique is key to have the best results.